Welcome back to Clinical Communication. My name is Ben. I'm a specialist physio and clinical communication skills facilitator here in the UK. And today I'm speaking with my good friend Adam Dobson, who's an advanced physiotherapy practitioner in spinal pain. And today we're discussing Adam's special interest around back or spine-related nerve pain, terminologies to use, how to explain it to patients. And we also discuss about imaging with patients, how to discuss when is the right time with patients, when it's not appropriate, and how to discuss results as well. If you find this helpful and useful, please do subscribe and also give suggestions about what would make it better. Thank you for watching or listening. I'll see you next time.
He won't. No.
I did search this actually like yesterday before we started. There's no one who's got the moniker of the space physio yet.
Yeah.
So if you're looking for a shift, I don't know if NASA are sending up medical people yet. Uh,
Yeah, I'm probably more of an enthusiast than a kind of a techie. I'm not particularly good at physics,
no?
and things like that. I wouldn't say. Those things kind of fry my brain a little bit. But I'm more into the wonder and the kind of possibility of life on different planets and those kind of things. But yeah, I'd take that handle on the space physio.
Space physio. Why not?
Yeah.
I mean, that's interesting conversation. If the NASA physical therapist or whoever they are or doctor,
Yeah.
I'm sure
But
some
I'm
of
I'm I'm hands off though, Ben. So
well, if they're floating around, you won't be able to touch them anyway.
yeah. Yeah, probably not.
So
Anyway.
we should talk about what people have clicked on this to listen to,
Mhm.
and what about. And thank you for doing this, by the way, and giving up your
So
evening to speak to me. Um,
always a
we
pleasure, Ben.
likewise. Um, you've we spoke about this before we started that we're going to talk about nerves and terminology with it, imaging, uh, the hardest conversation, and some positive experiences from spinal patients as well. We will tell people now in advance, and I will say this that today we're not talking about specific clinical reasoning for nerve or suspected nerve related pain. Adam has a website for that, and various other podcasts and various other resources which you can go and look at. We're just focusing on certain conversations around these things we've mentioned. If I give you an example, because I have a patient I spoke in the last show with Rob about that I'm going to bring forwards for this one, who is Steve, who's in his 50s, who's got back and left leg pain. And let's say you've assessed Steve, uh, and it all fits with this kind of left leg pain that seems related to his back. When he moves his back, it hurts his leg. His straight leg raise is very positive. It's all fitting the bill. He might have some tingling as well, which fits. No significant neurology, but it all just fits a pattern. You've assessed him, um, and then he's going to ask what's going on. Um, what's the right lingo to say to Steve
Mm.
regarding his back and leg pain?
Um, so I think probably preface to say what maybe isn't going on. So I'm pretty thorough. The case that you described, Ben, seems fairly tacked on, fairly bland or
Yeah.
presentation. The patient essentially is telling you the diagnosis, etc., that kind of thing. We want to listen to our patient, we want to hear them out, but it sounds pretty tacked on. I like to kind of talk around a couple of things. So I'll always examine the hip, and we'll say, hips feel okay, hips move well. Um, I'm kind of big on kind of saying, look, your nerves seem to be functioning okay, and I'm big on using models and things. So I don't think when it's appropriate, I think it's perfectly okay to talk about structure. I have got some caveats to that, so I'll maybe come to. But using the model, we say, reflexes are okay, power is okay, and I test those, screen those on all of my patients. And I like to kind of like a bit of a good news, bad news, good news kind of sandwich. And that is my good news piece of bread. Is saying that nice crusty piece of bread. that their nerves are functioning well and normal, and that usually indicates that their nerves are doing okay.
Mm.
There's an argument to say that if you have radicular pain, that is an indication of nerve injury, and that is a good argument. But I think you've got to be sensible in how you package that up. So no radiculopathy, nerve function's okay. We'll talk about that. Use the model. And then I may refer to their anatomy. It says nerve-related pain. I'll talk maybe about a bit of a physiological process, but it's nice to use analogies like this nerve is sensitive,
Yeah.
this nerve is irritable. These things are useful because irritability can reduce, sensitivity can reduce. They give the sense of reversibility. So that this nerve sore. Am I allowed to swear, Ben? A
Yes.
small
Yeah,
swear
yeah, yeah,
word.
yeah. I can put, yeah.
Beat me out in post.
It's all right.
So I might say your nerve is pissed off.
Oh yeah, I say that as well. Yeah,
And
yeah.
and I use that. You've heard that analogy. Poke your eyeball; it doesn't hurt. Stick a little bit of chili in your eyeball; that'll hurt your eye to poke now. So it's not harmful to your eyeball to be poked, but it's really sore,
Yeah.
and that's kind of what's going on around a nerve root in your back. So those are the types of analogies that I use. They may bring up the word sciatica, which is fine. If I will use the word sciatica, we've had a discussion about this, but I'll probably repackage that word sciatica to specifically refer to a nerve root problem,
Yeah.
to opposed to just kind of any degree of leg pain. But in those cases that they have that condition, then there's less ambiguity, less uncertainty. Then I think it's reasonable to say to use that word. Just kind of make sure that we're using it in an appropriate manner.
I have interest with the sciatica. If he says, oh, I've got sciatica, and he's actually got front of thigh
Mm.
femoral distribution, would you correct him? Or if that's the term he's using to describe his nerve leg pain, would you
Well,
ignore
well,
that?
uh, I suppose it depends. It depends how important I feel that is to know. These aren't technically, we could argue about it, but these aren't femoral nerve problems. These are upper lumbar nerve problems, and I tend to call those all the same thing.
Mm.
So they're all nerve root pain. They're all sciatica, and often we get people saying, "I can feel it in the front of my leg. It's not sciatica. I've had that before." And so, well, you can have it in any part of your leg. Um, and talk them through the various bits of my thinking, and say, it can well, kind of manifest in your thigh. So I think if you explain things through, you're not really challenging patients as much, you're just having a conversation. Then, and if you have a high degree of confidence that that's what it is, it's perfectly okay. But if someone, equally, if someone is very strongly feels a certain way, I probably wouldn't always challenge that. It just depends on how interested the patient is, what level of confidence I have, what implications that might have. Because if we're going to look at things like nerve root injections, then they might wonder why we're not putting that injection in the leg,
Yeah, yeah.
or their groin.
You said there were caveats with using the model. What's your caveats?
Yeah, so I try not to, as much as possible, until we get to the end. I try not to introduce pathoanatomical terminology, discs mainly, the word disc. It's just unless the patient specifically brings it up. So I think if the conversation's going in a direction that this is just not relevant, we don't need to talk about structure. and there are other variables that we've identified that might be relevant. I'd rather put the focus on those things and kind of go, these are valid reasons,
Mm.
than always feel the need to kind of defend it's not your structure position. Um, so if at the end, I might talk about how their safety, and I might talk, talk about I've assessed certain things. But during the conversation, I wouldn't make a point to kind of bring that nomenclature up unless the patient really wants to talk about it.
Yeah. I'm thinking of the people in primary care, your GP, FCP, or anyone who's seeing, maybe they're seeing this person, they're the first person this patient's seeing. Um, and they do as you say, they say it's sore, a bit sensitive, but try to give reassurance, say, well, it's not. And Steve turns around and says, so is it trapped? Um, what should we say at that point if he's questioning, is my nerve actually trapped?
Um, well, if they have a degree of nerve radiculopathy, I'm not sure. Maybe Steve has developed a little bit of weakness in his leg,
Sometimes. Yeah.
and then the most probable reason is disc related compression, nerve related compression, and if we're going to use that as another word for trapped, then we could maybe talk about that. I think it's really important that we don't lie to patients,
Mm,
and that we don't try and sell it as anything. We can be sensible with our language, but I think there are certain times when we just need to be honest and say, yeah, this nerve's probably having a bit of a hard time,
yeah.
and I'm not kind of always averse to disc related, disc herniation terminology, because that is the main reason that nerves become compressed. It's the main structure,
Yeah.
and I do see that,
Mm,
um, so in those cases, I might kind of maybe talk about what they mean
yeah.
about the word trapped, and maybe reframe that as compression if it's relevant. But equally, when as you will know, Ben, when you talk to people, sharp pain, it feels like something's being trapped. These are often attempts to try and describe an experience that they're having.
Yeah.
So I wouldn't always challenge that. If it was a patient with back pain, I'd maybe go towards the end and say your nerves are working okay. Da, 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 da. But if someone it feels trapped,
Mm.
who's us to kind of go? But it isn't though. All right, you do
Yeah.
get that, yeah.
Yeah.
It's you've kind of pick your battles, I suppose, haven't it?
Yeah. Yeah.
And how relevant is that to kind of pick up on? Are they going to appreciate you doing that?
Yeah.
And could that be something that you maybe store for later? Which they're not revolutionary ideas.
If they don't have the weakness, the numbness, or other signs of compression, can you say if they ask that and they just have pain, um, could you say with confidence, no, it's probably not
Um,
trapped? Just
well, if they're relating to nerve roots, I think so.
okay.
Yeah.
Okay.
I think I don't think that would be helpful to suggest otherwise.
Okay.
What do you think, Ben?
I think I'm not as nowhere near a nerve expert as you are. I will use the same thing that you say, which is it is pissed off or sensitive.
Mm.
Um, uh, I am blessed. I don't know if this is a blessing or a curse that where I am, everyone's been scanned, and they've already been told to about nerves, what the scan shows. And obviously, we know there's more to life than scans and more, etc. But if they
Mm.
say, "Is there compression on my scan?" Well, I can turn around and say, "Well, the report says X. This is how relevant it is or isn't." Um,
Yeah.
but I do often because we know from stuff that you said in the past, Tom's Justin said, many other people have said that it's not just those things being compressed. There's inflammatory chemicals. There's
Mm.
all sorts of stuff going on. So I will often use the term, sensitive, irritated, um, whatever
Yeah,
comes
I
up.
think if they don't have a radiculopathy, we can say that nerve's not injured, or we can, or something approaching that it's not
Mm,
injured. So if we're going with terminology like irritable, it's sensitive, there may be a level of inflammation around
mm,
this nerve.
mm.
Um, then 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 yeah, I think that's reasonable.
I'm just thinking again that the people in primary care,
Mm.
they've said this to Steve, explain what's going on, and Steve they suggest whatever treatment they want to suggest, whether it's certain exercises, medications, whatever first line measures they're going to suggest. And Steve's walking out, and he says, "Will this get better?" And let's say at this point he's only had it for a month. Um, in that point, what would you suggest people say?
So there is a little bit of work done at looking at trajectories. So it's not quite looking at their prognosis as such, because the patients come into the study with various degrees of time frames in the scopic trial. But it gives you a general kind of feel for how long these things take. And I have I dare say a little bit of a script with that, but it's a case of by 12 weeks, 3 months, 50% of people have recovered. Okay, so we can say at this point that this is a probability. We're not going to say it's going to take 12 weeks, but based on normal examination, the time frame, this is in our favor. And there's things that we can do that are going to be helpful, and nerves love to move, etc., etc. So we're making a best educated guess at that point in time, and then we can change our minds and review it further down the line.
Yeah.
But I don't think that you can say more than that really. There are some people who will unfortunately have these problems for many months.
Yes.
So you give your best explanation at that point, but say this is a probability. We can't be 100%, but based on what we know, this sounds good to me.
Mm,
And then we can review them, and we can update our thinking on that, and talk about their options and their preferences, and we can reassess them and use new data. And that's the way. That's the way. But I think you've also got to kind of say, if the problem's starting to look at several months,
mm,
I think you maybe need to go. This may be a problem that's going to take a while.
yeah.
So then we can maybe change our terminology a little bit, as the problem is not showing improvement when we meet them the next time. But we need to be hopeful but honest,
Yeah.
and based on uncertain data.
Yes. It's a very fine line, isn't it?
Yeah.
Trying to find that point. And I know obviously there's other differentials for back and leg pain that isn't just nerve related. I'm thinking specifically because we were talking about vascular stuff before we started recording.
Yeah.
Let's say if I change Steve a little bit, he still has his back pain, but now he's got symptoms in both legs and his lower legs. And initially, he's been to see someone who thought it was more spinal stenosis, nerve related um, situation. And then he's come in to see, he's been referred on to see a clinician, whether it's in specialist services or in secondary care, wherever it is. Clinicians assess them. They feel actually, you know what, Steve's symptoms in his legs appear much more vascular than they do nerve related, and it's different. And you can see the difference. He has to actually sit down, not just lean forwards for it to get better. There's visible skin changes starting to occur. Maybe they've even checked the pulses and can feel difference there as well. Perhaps. How Steve's come in with an expectation of this is back and then nerve related, not at all expecting this to be blood related at all. How would
Mm.
you go about this conversation of telling, well, it's actually not your back and nerves, it's actually more your blood supply?
Yeah. Um, I I think we need to know what Steve understands first of all, don't we? We need to recap previous encounters, previous conversations, understand what Steve's understanding of the problem is, how he understands those things, his expectations, how he's forming that information. Maybe it's based on scans and things like that. Um, the examination itself is actually a very helpful educational tool. Um, so I do put a portion of my history and during the exam, and patients quite like changing positions and have a little bit of a chat in this position, chat in this position. Um, and we could corroborate some of those findings that have been said. You know, it might be that you want to check those things out yourself. Um, I'd want to be, well, probably don't want to get too much into the clinical, but has he had an ABPI investigation, for instance? How certain are we that this is a vascular problem? If he's getting skin changes, Ben,
Mm-hmm.
I'd I'd be a little concerned that this is kind of going south a
Mm.
little quickly. If he's developing skin changes, he's chronic to critical ischemia. I don't know what time frame he's developed these problems over, but presumably he's seen these changes in his own legs. You know,
Mm.
what does Steve think about these changes in his legs? So kind of using that data and kind of ease him into, well, based on, I think we've had to kind of reformulate a different diagnosis, Steve, based on this information. We used to think it was this. I think it's quite helpful to kind of bring patients into your reasoning a little bit. So kind of say, well, because you had these features, we were thinking it was this. And it's kind of evolved and it's come into focus a little bit more. And now the skin on your feet's falling off. Um,
Mm.
and yeah, maybe not that extreme.
Maybe not
And
extreme then.
and we're thinking it may be, and then check his understanding. And that person might need some medical referral, or they may need some further workup to better understand that problem. But you kind of seeing where they're coming from, and if you let people speak,
Yeah.
if you let them talk it through, these things are quite easy, aren't they, Ben? When you give them a bit of space,
Yeah.
and check those things out, and then the examination kind of just adds to that, I think.
Mm.
Um, so yeah, I've a number of those cases where we thought it's one thing and turned out to be another. A patient who swore blind that it was sciatica because he had pain down into his leg, but he was telling me it hurts to take his leg in and out of the car. He was saying he can't put shoes on, that his groin was hurting as well, and he had the stiffest hip
Really?
I've ever felt. But he was, these were his words. I can tell you, I'll stop you there. I'll tell you what it is. It's that bloody sciatica again. And it wasn't.
No.
We did an X-ray on that guy, and he had literally no joint space,
Wow.
sclerotic hip, and we moved it. He moved on to a hip surgeon, but yeah,
How did he take the news when you told him it's not your sciatica, it's your hip joint?
he was surprised. He was curious, and by the time we saw him again and we had a bit more information, he was convinced. At that point, but because he was telling me the problem, it was very apparent with that chap. I wouldn't say it's always that easy. Somatic, referred, chronic cases, non-specific lower back related leg pain,
Mm.
which is a reasonable word. I see a lot of those uncertain cases. So we're not always getting light bulbs. And some of these patients have had lots of investigations that lead nowhere.
Mm.
You'll have seen those as well, Ben.
Yep.
And those they're in some way they're more difficult than those kind of other tissues, a strong feature here, kind of thing.
So in those complex situations where it's not barn door obvious and someone's had time and maybe input from primary or maybe secondary care and they're just not getting anywhere, and they see someone in specialist services or consultants, whoever, this person, as you say, may need further investigation. And one of the things we've talked about in the past, and you've shown me this document, is about um, imaging for screening and also for workup. Is that right?
Mm.
Um,
Yeah.
Before we delve into the specifics, what does that mean for those? Because they're different situations. What does that mean for either screening or workup?
Yeah, so it's probably a very loose way to look at the problem. It's a little bit blunt, but it's two general categories of approaches to imaging. So, screening is if we suspect A and we're looking to rule out A. So that might be with suspicion of sinister pathology. Um, and the other side of it is if it's likely to lead to a change of management. So the guy with the hip X-ray, we'd had a conversation about his preferences and his wishes. And if he didn't want to entertain a discussion with the orthopedic team, we probably wouldn't have done the X-ray.
Okay.
So that is a workup for the treatment is highly likely to be dependent on and influenced by the imaging. So it's kind of just two general categories of thinking about why we are referring people for scans.
The screening one,
Mm.
how much do you tell before? How much would you say to them before about why you're sending them for that imaging?
Yeah, so I'd just say I have since simplified that whole thing, by the way. I
Okay.
think that having those two categories theoretically is a nice idea. But
Mm.
when it comes to, based on a bit of feedback from the team
Mhm.
and a little bit of reflection, I think that could have. So now we just simply have um, you are being referred for, your specialist wants to check for, and then you can write any further details into it. But what was the question again?
So if in that, let's say you're checking for serious pathology in that case,
Mm.
how much you're going to tell this person you're going to send them off to a scan? How much would you say at that point about?
I would pretty explicit about why I was referring them for a scan.
Okay.
Yeah, so if um, we don't want any surprises, and we want to keep the utility of the imaging. We want to keep so imaging is an extension of your reasoning, isn't it? So a, a, a good decision to scan is based on having sound reasoning.
Mm.
So and a part of that is we need to communicate our thinking during the examination. So a good example would be if you suspect a fragility fracture.
Mm.
So you've got a lady in her 70s. She has a lot of pain laying down. She's developed acute pain,
Mm.
struggling to lay down, really tender with palpating through her back. It seemed to come on acutely.
Mm.
Maybe she's got some risk factors for osteoporosis. In those cases, we want to be pretty clear about I'm doing an X-ray because I have a concern that you've cracked a bone.
Yeah.
And I will talk about the nature of those types of fractures, but it is a serious pathology nonetheless.
Yeah.
Maybe not as dangerous as a hip fracture, but still, and they can be very painful as well. So patients are, when they have like acute pain, they can't lay on their back. It's helpful to know that the bone pain can be very painful.
Mm.
Um, so so we're doing that, and because I don't want the patient to become, if the X-ray comes back and there is evidence of fragility, I don't want the patient overly kind of caught out by that, because you can check these on NHS apps.
Yeah.
Sometimes our kind of review might be longer than we would like it to be.
Mm.
So patients are kind of left and they've got imaging results and reports, and that can be a bit alarming
Yes.
if you're not preparing someone for the potential for that. I've got another example of a really bad experience. I don't know if it like feeds into this,
Yeah,
but
go on.
um, so I had a patient who was really worried there was something serious going on. I hadn't actually done the imaging. The GP done the imaging, and the imaging kind of came with the patient. So the patient came through, imaging wasn't available yet. Um, Examination was okay, but patient was in a lot of distress, worry. I think she had a family member who'd had um, a cancer
Yeah.
that with bony metastases, so she was really worried about that. Um, had a sensible discussion. Right, okay, we'll call you with a result. I had a low index of suspicion. I didn't think this was going to be showing anything of that nature. It wasn't fitting. But the patient was very worried. Um, a lot of time had passed. She got access to the X-ray. Was it an X-ray, an MRI? One, two, MRI, and there was a hemangioma
Oh yeah.
on one of within one of the vertebrae. As you will know, a typical hemangioma is a benign finding.
Yeah.
But she picked this up, spoke to the GP, and the GP was kind of like, "Well, we can't rule out cancer." That was the exact words that we used with the patient. So now there was seemingly a anoma word, which is
Yeah.
an interesting no, it's not a prefix. What is it? For the word that comes after the word. So that prefix is before, isn't it?
Yeah. I don't know.
Postfix. Let's call
Yeah,
it
let's
that.
go to
It's
that.
not
Yeah.
post. And but we had not done that. I wasn't involved in the scan process, so we do, what was the reasoning, what was the counsel, and that could have probably have been avoided, despite the kind of lengthy wait for
Mm.
us to see us. And interestingly, when you're expecting bad news, um, or you're in a really horrible place with a problem, sometimes good news is bad news, isn't it?
Yeah. 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 Yeah.
Uh, so, no, hearing that this was actually not a problem, um, and then defaulting to, well, what is it then? I'm in this state.
Mm.
It actually didn't really go well
Mm.
at all. Inconsolable, and just kind of, struggled to kind of help the situation, I suppose. So it was like a bad situation made worse.
I was going to come to this later, but I will ask you now. Let's say this imaging is done. Um, the patient who you've seen is adamant you're going to find something, whatever it
Mm.
is. It could be disc protrusion, could be serious pathology, whatever. Scan comes back or imaging comes back, and it's okay. Essentially, there's maybe some expected age-related changes, but nothing otherwise that
Yeah.
needs anything invasive done. Um,
Mm.
how do you break the good news that is bad news to them?
Yeah, the reassurogram
Yeah.
debate, which I'm not a big fan of.
No, no.
I mean, the evidence for a reassurance from the evidence that we do have, it's not great evidence. There's a couple of studies, one by Rolf, and there's I can never say the second guy's name, beginning with RA. A couple of studies just looking at reassurance with scans, different types of scans, so not specifically for pain, but they're kind of in the mix. Doesn't seem to show that patients find scans very reassuring.
Mm.
So evidence doesn't support the reassurogram, I don't think. People make anecdotal accounts for why they disagree with that. And yes, there is a paucity of evidence in that area. But my experience is a little bit different. I think it's a bit of a perfect storm. That's how I've kind of referred to it before, because we know there will be findings.
Mm.
All right. So I think that there is an expectation going into a scan that all of these findings, disc bulges, facet arthrosis, that these are exception to normal aging, and that we wouldn't expect to see those things. Um, So we know those things are going to be there. And when we're trying to reassure them, what are we reassuring them of? Because if we think they're going to have those findings, they are worried that those findings are the cause. And then we inevitably see those findings.
Yeah.
Like, in a patient's mind, they're vindicated because they worried they had them problems and they do have those problems,
Yeah.
So without a high index of suspicion of a nerve root compression, a sinister pathology, specific pathology, inflammatory conditions, we're going to see what we expect to see.
Yeah.
But those things that we expect to see are seen as bad.
Yeah.
And there is a little bit about um, validating someone's experience by using, tissue, terminology, um, because we're trying to validate that their problem's real,
Mm.
and that it's valid and real,
Yeah.
and I don't think that is how we do that.
And I think you were talking about earlier about things being sensitive and people, these people, it's a small amount, but the patients who are adamant, that you're going to image them, they're going to find something that can then be done about it, and the imaging will come back inevitably, some people, as you said there, and it's all right. There's no target or nothing needs to be removed or anything like that. And you can use the pain sensitivity and you're trying to relate about pain and using pain in this example, but or about nerves still being sensitive if they're getting tingling and other symptoms with it. Um, Aside from that, are there in that situation when, let's say, with Steve, that his scans in this case may have come back like that, okay, or normal for his age. Are there any other ways you might help him understand why he's in all this pain?
Yeah, so we probably want to backtrack a little bit. We've kind of gone right to the
Yeah,
to that conversation, haven't we?
yeah,
Before I answer that question, just say that, in my experience, if if we don't act on findings, or if we sensibly explain that these are incidental or normal, or we'll talk about some limitations of kind of blaming structures and being honest about that,
mm,
I often find that leaves patients frustrated, and confused and angry. So if you do a scan, and we blame the stuff, but then we don't act on it,
yeah,
we're giving someone a problem with no solution. And I think that the downstream confusion, anger, frustration, kind of distrust with healthcare professionals, I think that can actually be caused by that situation.
mm,
And Because we haven't got an answer at the other end, we have at the business end. So that's the other side of reassurograms. Um, so when it comes to the kind of structural diagnostic labels, what is it? Imaging paradigms. Um, I think that you can put yourself in very good stead throughout the consultation. So you need to listen to your patient. We need to understand their understanding of their body,
yeah,
their expectations. So I'm, about the consultation today, but also their expectations about management, treatment. Some people, I wouldn't say all, but some people will, during that conversation, say, "Well, I think it's this, and I think I need this," and I like to have a conversation about things that you brought up. So we can, okay, I'm going to take a little mental note of that. We can come back to that. So that's one thing. More than not, though, what I tend to see is that people say they don't have any expectation, or they don't really know how to manage it or what should happen next.
mm,
But then at the very end, when you ask questions, it then comes out at that point.
yeah,
I'll say, I thought you were going to send me for a scan,
mhm,
but it seems to come out at the wrong time. It comes out at the question, your discussion element, um, rather than kind of where you'd expect it to. So you can't
mm,
always expect patients to kind of conform I'm expecting them to say this. Some would say you assume, societally speaking, that people have strong biomedical views, and they do. But on an individual basis, I don't want to assume
No,
anything.
no.
We'll just see what comes out the wash. So that's a bit ice, as you've spoke to a number of times. Towards the kind of business end, um, I often talk about ruling out pathology, ruling out dangerous things, talking about that they're safe, that certain movements might be safe, and we often do movement experiments, and that kind of brings out a lot. Often talk about the whys rather than the whats. So I've got a bit of a mood board. I don't know if you saw my picture on Twitter recently,
Right.
and I'm kind of holding a big A1 image up,
Okay.
like so I kind of developed a poster.
Yeah.
And I've got these like concentric circles. So I've got back specific factors like moving in protective ways, kind of, not moving your back enough, or
Okay.
lots of different factors. And then, but I call them like pieces of the pie. So
Yeah.
think about a pie. These are individual pieces. One of the pieces is structure. And then all of these other pieces that intersect with whole person factors. And what I try to do is I'll sit down on my knee and I'll go, let me, from what you said, and we'll keep, this is what I think may be going on. And I'll use that, take the attention off my face a little bit, and I'll kind of talk about these variables. And that it might be why your body's sore, not what is sore, but why you're sore. So I talk about the whys, not the whats.
Yeah.
Um, that's one side of it. Only then, if it's starting to get quite, saucy, and they're going, well, I just want to, why can't I? Then I may talk about some of the lack of utility with imaging, and maybe then I'll talk about some of that, the prevalence of findings on scans if we did do a scan. But what I don't want to do is jump straight to, well, we know these findings are on scans. I don't want to start talking about scans if they've not introduced
Mm.
any information about
Yeah.
scans. I
Yeah.
think you can walk someone in a certain way and they go, well, I didn't want a scan. I don't, you know,
Yeah.
and that will be a bit different with each patient in different weightings. But we can maybe talk about an animation that I'm drawing, talking about pain locations, and how many structures in your back essentially give you pain in the same regions, and that
Yeah.
there's a lot of stuff in there
Mm.
that pretty much gives you pain in your posterior pelvis kind of thing. And I think that using visuals like that can be helpful.
All right. And on the flip side, obviously, Steve could be imaged, and there could be actually relevant compression, whether with the disc protrusion or some form of raminal stenosis, whatever it is. Uh, how do you have the conversation about actually there is something here that could be done, more is on offer, so to speak? And let's say he said to you that he'd open for more management, hence why you ordered the imaging. Um, People often talk
Mm.
about, when tell people they don't need imaging, which we'll come to, and about, not, as we said, when things aren't there, but when things are there, um,
Mm.
how should we phrase that without scaring him too much?
So similar. We're going to be examining them. We're going to be taking a history. Obviously, there may be some more pertinent elements to the examination. In Steve's case, it's got some sensitivity with a straight leg raise, um, and he hasn't got radiculopathy. He's got no weakness. I think he was saying, Ben.
Well, if we're going to say he's got compression on the scan, we'll give him a bit of weakness now.
Okay.
The numbers.
Um, and we, so I kind of orientate people to scans. So I don't just jump in and go, seen this here,
Yeah.
massive. I'll go, whoo, it's a big one. But well, not in this context anyway. I like to kind of ease people in, so kind of orientating them to different planes of imaging, posterior, anterior, use the model and kind of go, this is where we're looking at. and I'll talk them through the back to the front. So I'll talk about this is fat tissue. This is where these bones are, and then this is where your spinal canal is. This is where the nerves run down, and then we'll move it into the column, and then I'll kind of work down to the level, and I'll talk about what we're seeing, but also their relevance. So the interpretation, and the correlation of that with any imaging. Interestingly, we get nerve abutment, nerve impingement,
Yeah.
nerve thecal sac contact.
Yeah.
These are so common in almost everyone. And they all get reported. I mean, the word impingement's not nice. I don't care what you say. Impinging, it's not a nice word. And we see these things in people where they've got no leg pain at all. We're not convinced that they have a nerve root problem. But then we see it in people who have some leg pain, and it becomes quite uncertain. And I'm very, very keen to talk them through and say, this could perhaps have some bearing on your symptoms. But then I'll also give them the flip side and say, but the other side of that is, this is quite a normal finding anyway.
Yeah.
And this might have no relevance of your symptoms. And I'll weigh that up against the examination, confidence. And I'll say, I'm a bit middling on this. You've had this problem for a long time, in acute cases. And also, I think that when it comes to imaging, investigations, nerve injection, it's less the doing the injection. It's more that, like, do I think that would actually work? And go, well, we can see this, and there is now. I know you've been told this, and this, but we could do a block. But if you want my honest opinion, like, I'm not so sure it would work or not. I'm not so sure if we've got much to go on to predict your outcome. I'm not saying it wouldn't, and then I'll talk them to the pros and the cons of doing such a thing. And so the other side of it, this is a chronic problem. It's even if it does work, it's unlikely to be curative. And then we need to have some other awkward or some further conversations about this is a long-term condition. So we get a lot of the impingements and the abutments, and almost in everyone. It's when it's at every level, lateral recess narrowing, and it's a very normal phenomenon.
Abutment, for those that won't know, just means touch. Is that right?
Yeah.
It's not compressing or doing. It's just in contact.
Yeah. I mean, yeah. So impinging, abutting, contacting. They sometimes say contacting. There will be a few other words in there as well. Those things that there is some approximation between a nerve structure and a soft tissue, if that be the disc, the lateral recess, or through the neural frame. But those nerves are pretty happy with that situation. I don't think that is, a lot of this is inflammatory, with acute disc herniations, that they're quite a different animal, to, like, an acute disc herniation is a different animal to a slight disc bulge that's been there for a long time, that may or may not be annoying that nerve. And so I'll give people an honest answer and allow them to think about their options.
Yeah. Wow. And if I change, I'll get to the question that I'm sure people want us to answer. If we change Steve's symptoms slightly, in that he had back and leg pain, he was referred somewhere. His leg symptoms have since resolved, and he's just got back pain now, and there's no signs of anything serious. He hasn't had any actual support apart from the referral, maybe some medications. And he's, I say it's been 3 months. He's keen for the imaging, but you don't think it's not appropriate reasoning wise. He hasn't had appropriate care. and there's no indication for it. Um, I've given my opinion in the past, but how would you manage the conversation of actually this isn't necessary at this point?
So I think it's helpful to have other, we've done some movement, so it's very common. You do movement experimentation. This is why I think it's best not to rush the process, to
Mm,
to let it stew a little bit. And these things often just kind of come out, don't they? I think about maybe taking up this activity, or I think this would be good for me.
yeah.
And I think there are little kind of things that you can pull on and go, I think this would be a good idea. Anyway, so that's a part of it. So you can tease out a couple of things that your patient may have mentioned or that they've done before. The movement experimentation, the cognitive functional therapy approach, it's not an approach, it's a framework, um, is very helpful because avoidant behavior is, I see that in almost everyone
Mm,
to some degree. And some patients will literally, like, they will say, I'm scared. I'm scared to bend. I'm worried. I'm fearful. And that can be quite powerful, can't it? That can be a powerful conversation that you're having with your patient. So give people other reasons to think, other valid and kind of realistic reasons that we could focus on and change,
yeah.
that there have been shown to be helpful. So for you've got to give someone a lifeline. You've got to give them other options, don't you? And otherwise, whatever you say at the end, they're gonna not like what you're selling.
Mm,
Um, so that can be useful, and see what conversations come from that. The other side of it is I am just kind of very, at some point, someone needs to have an honest conversation
yeah.
with a patient. And I've become a little bit hardened to this. I'm quite comfortable saying, look, this is a long-term condition.
Mm,
This is, um, we'll talk about the likely outcomes of imaging and the reasons when the utility of imaging is high and when it's not high. We may have a talk about what we're likely to see. And that this is not likely to be helping us help you.
yeah.
And then I'll go, well, maybe it'll tell me what is wrong, and we'll have a conversation about that. And I have to say that some people, and I've used this term before, it's kind of like bereaving a reality
Mm,
that doesn't exist anymore. Um,
yeah.
so when you're giving people bad news, and you've got to allow them to sit with those emotions, don't try and change those emotions,
Yeah.
be a lifeline. So we can come back to this. We run a residential program that is endlessly helpful for patients like Steve.
Mm,
Um, but and there is the other side of it is, and I did it just last week. I referred for someone for a scan because they were so insistent,
mm,
and essentially our relationship was breaking down as a consequence. And but I have mixed feelings on that because I know how that conversation is going to go when we get the scan. Um, but I'm not completely against doing that all the time. I'll probably say that's an exception
yeah.
than the rule. And I'm probably the most conservative member in our team.
Okay.
I refer for the least amount of imaging. I refer for the least amount of blocks.
Mhm.
Yeah. So that probably says something about me, Ben, I suppose.
But I think because you do this spinal program, which we're going to come to shortly.
Mm,
So I guess we've all got our little biases, don't we? Um,
of
um,
course.
and actually, I was our neurosurgical team where I am. They say, because the amount of spinal surgery that's been done compared to in the past is much less, and they say,
Yeah.
the people they assess, they may only actually list 2 or 3 people a month for surgery, because a lot of them are
Yeah.
just not appropriate. Oh, it's we know now compared to 20 odd years ago that actually, you know, spinal surgery can a lot of times not have good outcomes.
Yeah.
Um, Now, some people it can obviously have good outcomes for, otherwise it wouldn't be done at all. Um, but it's certainly,
Yeah, we're finding that too, Ben, that our surgeons are, particularly the neurosurgery team, very sensible,
mm,
very approachable,
yeah,
uh, conservative when they need to be. And I wouldn't say they have an unwillingness to operate, but they're just kind of like, is this a good idea, or do we think we can? Do I feel like I can help you with this problem, etc. And our pathway to some degree has kind of meant that they're seeing more appropriate patients from us.
yeah,
So they can have they're more likely to be able to help, perhaps have a higher conversion rate.
yeah,
The other side of that, though, is the pathways themselves, and I had a number of discussions this week on this, doing a bit of a project on it, but the pathways themselves are so disjointed, even in a small area like in the northeast, so disjointed in the amount of referrals that are still just coming from GPs to surgeons directly is still a problem. Um, so they're not necessarily operating on these people, but they're still seeing a lot of people that they shouldn't be seeing through various routes. So the pathway itself is needing attention in different areas. So not necessarily the conversations and that are happening, but the pathways that those conversations belong to.
yeah, yeah. Oh, and that sort of it's obviously varies depending on where you are in the country
Of
or in the
course.
world, doesn't it? About what your pathway is and how and as you say, there's certainly it sounds like from that situation, people that shouldn't be sat in front of the spinal surgeon to begin with somehow still getting there,
Yeah,
even though it's not
but not in good time though.
no.
Well, in the sense that like if well, the waiting lists are going to get bigger, aren't they? So
Yeah,
how long is it going to take for you to see the surgeon might be a problem into itself,
yeah,
and then the expectation that you place on that consultation.
yeah. Before I go on to the prostate question, was there anything about nerves or scans you wanted to say that I haven't asked or we've missed?
Uh, don't know. I mean, I do find it interesting reviewing scans. I do find the medical side of thing. I do find it fascinating. Do you, Ben? Like, I love technology and I love
Mm.
bodies and I love people and I love bodies. I do find them interesting to look at, and you do some weird and
It's
wonderful things on this. On there.
it's been interesting in the job before I want to do now. You could get the report, but you wouldn't get imaging. Now, this job I'm in now, you get report and imaging. Actually, seeing the picture puts it in a
Yeah,
lot more context. Um, and like with using models, as you said, and the various now, everything has its pros and cons, right? Um, and for the right person, having that scan up and showing, look, actually, in this case, we're happy you're sore but safe, you're not going to cause yourself any harm, etc. It's great. Um, but I can also see it from the other side, where, as you said, someone's got multiple stenosis changes at multiple levels and various other changes, and you put that up in front of them with a report, could really scare them potentially.
Mm.
And you can do your best to normalize it, but what they say is it a picture makes a thousand words or something like that. Like that
Yeah.
picture is
You
going to
can't
be
unsee it. You can't
no,
unsee a scan. Can Yeah, I mean, we didn't really touch on this side of it, but yeah, it's Pandora's box is well and truly open.
yeah,
And not all information is good information, like knowledge isn't always power and all those kind of analogies. I think that it can influence your perspective, your behavior, your view of your body.
yeah,
And some of these scans are quite scary
yeah,
to read. They multi-level this and words like um what's that word that it came up before. There's a word to mean that it was kind of like obliterated.
Oh yeah.
The lateral recesses were obliterated, and I'm like, do they realize people are looking at these? Like, that is irresponsible. I think that's irresponsible. Even the word scoliosis is I've got strong feelings on, and we can reframe those things, can't we? Like the disc desiccation, we can say we narrowing a little bit of water content. It's normal over time. We can reframe the terms a little bit, can't we?
Yeah.
But if someone's got a obliteration on the scan, that's pretty hard to bring someone down from
Yeah.
reading something like that, isn't it?
And actually, they'll still remember the thing they heard first more, even though
Yeah.
you told them
Mm.
afterwards what it isn't. Like all the things that come out online about this celebrity did this, and then 2 days later it turns out they didn't do that thing. Well, the thing that made the headlines they ever remember is the thing that came out first. So that patient will, even if you normalize it and you can do your best as much as possible, as you said, if you've got obliterated lateral recesses on your scan, that's still going to be sitting there regardless of whatever's been
Yeah.
said.
And it seems to be that the sensible counsel, like you say, I get to meet people at different stages. So I've seen them 2 years ago, and then I'll see them again. And they're kind of still saying the same things that they said 2 years ago, even though I've met them in between and tried to reframe those things. But that's kind of that's kind of gone and then reverted back to those original. So it seems like the strong language, the saucy language, it seems to be easy to remember. You see someone in 1984, I saw someone and he said this about me. You very rarely see someone say, I saw a guy in 1984 and he said, oh, your spine looks all right.
Okay.
Um, so there's something about that, isn't
So the other thing we talked about this just before um, we started recording this. You said you have the interest in prostates. Um,
it? Mm.
And patients come in with their back and leg pain, obviously, maybe not expecting to talk about prostates, but it is something we do talk about, obviously, their cauda equina and the urinary functions and all that side of things. How does one bring up and discuss the topic of prostates when it comes to back and leg pain?
Mm. Um, So I ask about. I'm very keen to hear about people's bladder function, Ben. I'm like strangely interested in people. Tell me about your bladder, in particularly in men of a certain age. So I'm always interested to know if there's been any changes in their flow, their ability to initiate a flow, for instance, frequency, any urinary infections. Um, in those cases, I'm very keen, if I feel it necessary, for my patients to go get that checked out. I'm an advocate of a prostate charity, and that is important to me.
Okay.
So that is a little bit of a personal bias, but I will always check that. I think it's important to check that in men, particularly, and I'm a man getting older, so I kind of, I feel like I'm talking to myself a little bit when I ask for people. So that's the side of it. In terms of the prostate relationship with their pain, um, so prostate is, as you will know, can metastasize to bone. So usually, if a patient's developed acute onset back pain, and I'd be asking if they had a previous history of prostate cancer.
Okay.
Check their blood, so PSA. When's the last time they had that examined? So it's usually in the presence of an existing diagnosis. Now, that being said, I did have an experience a little while ago where I encountered a gentleman with acute onset back pain. Nothing out of the ordinary was going on. asked all the right questions. It's a new problem. I think it's like mid to late 40s, young person, not something that you would necessarily suspect of something like that. No apparent that I can remember any apparent bladder problems. Um, Sent them away. Fine. Okay. Come back to me if there's any problem. And then they must have encountered their GP, and the GP had something may have changed during that consultation with me. GP had had a scan. At the same time, had referred back through to us, and I'd met him again, and the scan had just become available. Oh God, it's a bit of a awful one. And I did a whole spine scan, so it's kind of covering you top to toe, and it revealed a high level of bony metastases throughout his spine, and several other places. Now, just because of like the timing in which that had come through, I don't think that the GP was overly suspecting. I'm not quite so sure what was going on there, but referred through to us. So the timing was as such that I'd met him at a certain point when certain conversations had not happened yet. And we'd essentially, so I had a decision to make. I could talk about his scan and take that responsibility on. In this particular case, I didn't. I said, look, there's something concerning on the scan. I'm going to speak to your primary care physician, and we're going to have them contact you. But he could tell in my eyes that something wasn't right. And we just kind of stared at each other for a while. And he teared up and I teared up. And I said, look, well, the GP is going to call him. I think the GP actually went to see him at home. And that person's not much older than I am at that point. And so he'd had a primary prostate that had gone undetected, I suppose. But very unusual. And, I didn't give him the bad news, actually. I don't feel it's perhaps my place to do that without me referring for the imaging. And primary care physicians are very adept and professional and experienced in doing these things. So that was a bit of an ordeal. I don't know if you've had any similar experiences, Ben.
So my only person with cancer who I've happened to come across, which wasn't detected, it was ages ago. It was we're talking 6, 7 years ago now. This chap had, I think he'd broken his hip or something. He'd come into physio for rehab, and or maybe just had a fall, but nothing significant. Um, and I remember him coming in for his rehab and sitting down, and he just something was off. They say about the gut feel,
Yeah.
right? And my gut that day was just saying something's not quite right. This chap he's in his, I think, 70s, 80s. And it's not quite fitting. It just seemed a lot worse than it should be, basically.
Mm.
And he's struggling to weight bear, etc. And I'm just thinking, why? I got my senior colleague at the time to come in, had a look as well. It's like, okay, we'll order an X-ray and we'll get back to you. He left, and she turned to me and she's like, he is not well. Right, this is not good. And now looking back on it, I could see, he was in a late stage of what turned out to be, I think it was around his iliac crest and various other anatomy around there. He had quite a lot of metastases there. again, similar to yours, picked up by um, primary care GP or whoever, and then yeah, went on to have treatment in hospice.
Mm.
Um, I never saw him after that. After he went off for the
Yeah.
X-ray, you know,
Me neither. I don't know what the outcome was. I don't know how that gentleman got on. Um, but just a very strong, visceral experience
yes,
in the middle of a otherwise uneventful, Friday afternoon. But and we get cases, similar cases like this, sparingly
mm,
um, in the service. Cases that we have a suspicion and we've referred them for. But it was just accumulation of things and just a very interesting, very human experience, very humbling experience where we didn't really say much.
yeah,
And we just kind of sat together for a while. I know it sounds a little bit soft, but there really was no words, to and I didn't really want to say. I wanted him to have the right information as soon as possible, but I didn't really feel that it was my place to do so. I kind of like just like kind of dropping that on him.
yeah,
When he was coming for what he seemed to think was a routine back pain appointment
yeah.
for a problem that hadn't got, so yeah, that's a bit dreary, that isn't it,
No,
Ben?
but I'm grateful for sharing though, because actually it's real life, isn't it? You know, these things
Yeah.
happen. Not everything is plain sailing. Is that I normally ask about hardest conversations. Is that your hardest conversation?
Well, we didn't really have a conversation. Difficult, probably in different ways, but yeah, up there as a difficult encounter,
Yeah,
um, uh, um, a real encounter. These things are difficult in different ways, aren't they?
yeah,
You can feel. I have to say, in my career, I've often felt quite helpless in certain situations where someone is pleading to you, with it's essentially non-specific lower back pain. You know that these things can ruin people's lives,
yeah,
and they can be. They're not all success stories. They're not all where people have made great strides and been open to changes on the back to health programs. Been many cases where we don't seem to be able to make any inroads. Uh, Often being highly investigated, and we're just kind of out of options, I suppose, in terms of where to move. They're quite difficult, aren't they? Where maybe you've met someone a few times, and we don't seem to be able to get traction
yeah,
with a change. And I see a lot of young people as well. Um, I don't think it ever becomes fair, actually. Chronic pain. I don't think you get to a certain age and you just accept it.
mm,
I don't think that happens. It doesn't seem to be the case that you just kind of where you can gain a level of acceptance and say, this is where I am, but we're going to make some change. But that's a different thing, I think. But the idea that you are kind of just kind of going, it's here, we'll make no change. I'm just going to admit to the lack of control, and the unfairness of it all. I don't think that anyone ever kind of comes to terms with that. And it's not, it seems to be age appropriate. It can be 50, it can be 20. This is not something that's sitting well with you.
yeah.
And it's massively influencing your identity. Um, and those are difficult, aren't they? Where there are certain expectations about what you should be able to do or what you can do,
Yeah.
and you're not able to provide that.
And I was talking about this with colleagues earlier, like whether it's social media, whether it's TV programs these days that show, you know, the surgeons or whoever doing miraculous things. Um, it sets up healthcare to be this panacea in a way, or this kind of, you know, they will eventually fix it.
Mm.
and pain at least is not as simple as that. Um, you know, we saw someone with a consultant earlier in the week who's just of that example you gave, just a not just but a persistent low back pain, but that's ruining their life. Who's still looking for a fix or solution, and basically being told, you know, there probably isn't going to be one. Um, and it's just whether it's maybe in time it gets easier for people to hear. Do you find out of interest that this is only from my experience, those that are younger find it harder compared to those that are older because they still have, in theory, more of a life they they could have had. That makes sense compared to the older ones.
Yeah, like I said, I think on paper that might be the case, but I meet people of all different age groups who essentially are still not at that place.
Yeah,
Of I think there are different ways to look at it, isn't there? Like the acceptance thing, the ACT model, accepting that pain is here, and and then looking to rehabilitate and make changes. It's not quite the same as, so well, I've got to live with it,
yeah,
and I'm becoming increasingly isolated, and it's affecting my mental health,
yeah.
but a lot, we see a lot of young people where their kind of whole life declines, so their relationships and their social life and their work, and those things. And interesting, we get a fair amount of young people on the Back to Health program, and they're particularly uh, satisfying to help
Yeah.
people with, because yeah, they've got a whole life ahead of them. And I have a 21-year-old daughter, and we get a lot of 21-year-olds on the program, and I kind of like, so they could be my daughter. And interestingly, my daughter suffers with chronic pain. I don't know if I mentioned
No,
it.
no, no.
She's she she has chronic back pain, episodically. She's complaining of her back, and she's had two operations on her knee,
Okay.
had a meniscal repair, and then recently she had a locked knee, and she's had to have another operation. She's dislocated her elbow.
No.
She's broke her hand, dislocated her thumb. I think that some people have a predisposition to pain and musculoskeletal conditions, and she's certainly one of them. But she's very resilient, and she's taken my advice finally and joined a gym.
Okay.
Um, but and I get a lot of young people on the program who are kind of in the formative years, and they develop these pain problems, and it does affect all aspects of their life, doesn't it?
Yeah.
Working, relationships, um, coping. These they kind of come for the ride, don't they? I don't think it's exclusive to young people, but
No.
it's very notable in young people, I suppose.
Well, let's end this you on a positive. You have your back to health program. I run a back pain management program as well. So I asked before we recorded this, and I told you what I'd ask. What are some of the biggest turnarounds, biggest changes, improvements you've seen in people come through your program?
I don't know if I think it's just the consistent. And this is really boring to be honest about, but it's just the consistent ability to change your mind on something. So changing someone's mind is actually a lot harder than you think, or have someone change their mind on something. And we only really, towards the end of the first week, it's an intensive program, 3 weeks. Towards the end of the first week, into the second week, definitely by the beginning of the third week. But that's still quite a lot of intensive input.
Mm.
Um, but for someone, towards the third week, when we're having our regular one-to-one conversations, and people are generally saying, you know what, I'm not scared of it anymore, and and I think just those like key messages that we try to that you're safe to move, that kind of deepening their understanding of the imaging conundrum.
Yeah,
Like they become kind of like mini physios in a sense.
yeah,
And that is a consistent finding that we see.
yeah,
And that is infinitely gratifying. And I think the support they get from everyone on the program. Beyond that, we've had a number of people who are essentially paid free, Ben, which I'm always kind of like, how did that happen? But but we have, and that's fantastic. But we don't set that out as an expectation for everyone. Say, look, this is uncertain. It's possible though, and we have previous guest speakers who've come in. One of which doesn't have any pain at all, and she talks about her story, which is amazing to see. It's hopeful for patients. But I kind of prefer it when people kind of regain their habits, and we've had a lot of people get into work from being on the program. So I almost like it's like less about the pain and more about the life
yeah,
stuff. It's like I've got this, but now I'm in a new job, and
yeah,
and I'm coping better, and I've lost some weight, and seeing though, because we review people like up to a year down the line, and to see that still happen in a year is
yeah,
just like amazing.
yeah,
And there's always a bit of me nervous when I'm ringing them up at 6 months and six, oh, shit. Like, are they all have gone to pot? It's like, and then when I hear someone go, you know what, I've kept the swimming up, and I got that job, and we just feel like a little bit of like you've been involved in, you've kind of a little bit of you has contributed
yeah,
to that. So it's the little things, isn't it, Ben?
yeah.
How do you feel?
And actually the ones that come in back, so we see ours like you, we see them after the program that we then see them a month, 6 months, and a year later. I'm always a little bit worried if they come back at that 1 month or specifically 6 months and say I'm basically pain free. Um,
Yeah.
there's not many,
Mm.
but the ones that do, I'm always a bit like, oh God,
Oh yeah.
what if they come back at
Yeah.
12 and it's gone the other way again? Um,
Yeah.
Now that it's not, and sometimes it sticks, and that's fine.
Yeah.
But actually, the biggest wins are when they, as you say, most of them aren't pain free at the end. We're not setting that expectation either. But when, as you say, it's the big thing, like I'm back to work. I'm um, doing more of, I don't know, whether it's a physical hobby of golf or five-a-side.
Mm.
I'm doing more with my grandkids. The thing that you can see is just giving them more joy.
Mm.
I think that's the real where you feel, oh yes, we've achieved something, and like we've okay, yes, when someone's paying for you have improved their quality of life. But seeing that in someone who's still with their symptom, I think they've taken it on board and they're rolling with it. As you say, we don't see a big drastic change, most of them at the end of the 3 weeks.
Mm.
Because and
Yeah.
also you're taking people out of reality. The real
Yeah.
test is at the reviews afterwards at the month and down the line to see really how much has this stuck. um but it does add a nice change to to a um to a timetable. Some clinicians are bombarded 9 till 5 every day, 10 patients coming through or more coming through the door. I have that some days, but I also have other days where we're just doing this program and it's a group of 6 or 8 people that I've known for the past 3 weeks, and it's very much calmer.
Yeah.
Um, I know the nice guidelines at the moment are a bit on the fence about them, um, but for the right people, they can um,
Just the chronic pain guidelines then?
the
On
yeah
about that?
the chronic pain nice guidelines of what is it 2021 um,
Mm.
doesn't have a recommendation for pain management programs at the moment, um, due to not enough evidence, basically. But we'll see. And then the next review them what they say.
Yeah, the our program there is a recommendation for a combined physical and psychological program. But when is back pain chronic pain, Ben?
Yeah, exactly. Yeah,
Uh, you
yeah.
know, so they're kind of recommending it one and not for the other when it's just about semantics, really, isn't it? The but yeah, there are some plans for our program, some development and some research, hopefully. Um, so it should be something in our patch, and maybe in the future there'll be some expansion and some improvement of the current existing program. So I'm quite positive for the program into the future.
Yeah, yeah,
Um, and it's our little baby. Me and my colleague Ronan, it's our baby. And Claire, we've got a new admin assistant who's absolute gold dust with her contribution already taking a lot of jobs off our hands.
yeah.
And we're not used to this. We're not used to we're used to doing everything, like all the admin, all the calls, and all these types of things. And so it's. I mean, you never know where things are going to lie in 10 years, do you? But it looks promising for the program
Yeah.
and similar outfits.
We got admin support about a year to 18 months ago and made life so much better.
Yeah,
It just takes so much off your plate.
it
Um,
does.
uh, well, I've got it written down. So if people want to know more about everything you've got available, they can go to
Mm.
theridicularclinician.com. That's right.
Yes, that's correct.
And they can keep an eye out for courses to be announced next year.
Yeah.
People can find you online. I'll put your um, social media handle in the info. Um, then anything else I need to plug?
No, that's it. 2025 should be it should be a good year for me. Some things are coming to an end, and some things are going to come into fruition. So hopefully it'll be an enjoyable year.
And thank you for sharing all your stories, because it's
Thank you.
important that people obviously hear the challenges, but also the positives as well.
Thank
And we'll let people go. And thank you, mate.
you. Thank you, Ben. Thanks for having me.